It's a great honor to have been invited to give this memorial lecture, and I thank those of you who invited me. It's also a great pleasure to be here with you and to see how these international city health conferences are growing and becoming more important venues for discussing issues that otherwise we might not discuss. Urban health is something that is traditionally forgotten, neglected. It is something that is so political that even politicians don't want to deal with it. Today I'm going to try to give a brief overview of how I see the problem of urban health, the changing pattern of urbanization and its implications for health, not only for the health of those who move into urban areas, but also for the people who host them. And one of the things that is emerging now more than ever before is that when we look at migration, we have to think not only about those two entities, those who moved and those who received them, but we have to think about those they leave behind. And this is an aspect of migration that has been seriously overlooked. Today, when we talk about migration, it's probably most common to think about the vivid images that we see all too frequently of people trying to cross the Mediterranean from North Africa to Italy, to Greece, and to Malta. It's even more tragic when we think about how many people don't make it. But indicative of the force of the drivers of migration is the fact that there are approximately 800,000 people waiting to pay a lot of money to be taken across the Mediterranean in boats that are unlikely to make it. They pay up to $10,000 each for a trip that should take an hour and a half, but often takes days. The desire to move, the pressure to move, of course, is not new. And I always think about the English story of Dick Whittington, an orphan in the north of England, who had this vision that the streets of London were paved with gold, and ventured to go to London, accompanied only by his cat, to seek his fortune. He eventually did, and became Lord Mayor of London. But London at that time was a very chaotic place. And I want us to think carefully about what London was, because that tells us a little about what other cities are today. There is another aspect of migration, and that is that not only was the economic push a major factor, but there was also an inclination, and perhaps there still is today, to think of the city as the center of intellectual discussion and ideas. When Machiavelli was banished from the court of Florence, his punishment was to go under house arrest in a house in a small village from where he could see Venice in the distance, but he could not go there. And story has it that he would stand on the dusty road in front of his house, waiting for travelers coming out of Florence to ask them about the new ideas emerging in the vibrant center, for him, of the universe. The early pattern of rural to urban migration as we know it today was a confluence of factors. Rural agriculture was becoming more difficult. The factory system was becoming more appealing. And it opened up a whole avenue of work for women. And this was long before, of course, anyone was worried about the rights of women. But opening industry up to women meant an additional income to families. But London really was a chaotic place, and it was a broken promise. London at that time had a population of over 100,000 people who came under the category of the underclass. I think what Germans would call the Lumpenproletariat, something Marx would have done, who lived in absolute squalor, cleaning sewers, doing things that no one else would do. There were so many of them that it is estimated that if they had split away from London at that time, they would have created the 5th largest city in England in the 1800s. Had it not been for the likes of people like Robert Koch in Germany, John Snow in England, and Henry Whitehead in England, the lives of this 100,000 people would have been even more tragic than it was. Robert Koch identified the cholera vibria. John Snow and Reverend Henry Whitehead decided that the task for them was to try to map where cholera was spreading from. At the same time, there were other, what I would call early social scientists and people who were beginning to experiment with what today we call GIS systems, who began to more thoroughly map poverty in London. Had it not been for these 4 people and others like them, cholera would have continued to wipe out the population of London. And Stephen Johnson, who wrote an extraordinary book about that period, says that such was the mortality in London at that time, that had there not been a continuing flow of migrants from rural areas, London would not have survived as a city. So, together, and in a situation in which a unique set of circumstances came to play, including a willingness on the part of politicians and parliamentarians to take evidence into action and to stop the poisonous pumps, had it not been for the fact that England at that time was going through an extraordinary economic growth, during that period, the income per head, the economic production per head, rose by 500%, something that we have never seen anyone else and since then. And gave rise also to a group of people who were convinced that environmental engineering was the way to deal with cholera and other diseases. And Bazalgette was one of those people who began the great tunneling that produced the water and sewage systems for London, and in so doing was able to get rid of waste in a way that protected the population of London. Despite this, however, there is no doubt that the authorities of London paid very little attention to the needs of migrants. Migrants coming in were like cattle fodder. They were like the people you send up in battles on the front lines. They were needed. It was understood that they were needed, but they were not valued. This is a problem today, by the way, with our contemporary problem of migration, or our challenge of migration. So these people joined the ranks of the 100,000 underclass, the Lumpenproletariat. And they lived and they died with what at that time was called consumption and what today we know as TB. They suffered from a range of other respiratory diseases that reflected the horrendous environmental pollution that they lived in. They suffered from gross malnutrition because there were constant food shortages and they couldn't afford food anyway, and what food they could buy was of such horrendous quality that it didn't help them. They suffered from waterborne diseases, of which cholera was perhaps the worst, but by no means the only one. And they suffered from sexually transmitted diseases that come with any accumulation of congregation or concentration of people in a situation of social chaos and disorder. They also died of smallpox, and that is something that we tend to forget these days. Smallpox was a big killer in the urban environment of Europe at that time. The 1800s is not that long ago. And they suffered tremendously from both accidental and intentional injuries. WHO makes this wonderful academic distinction between intentional and accidental injuries. Accidental comes from you tripping up over something. Intentional because this person sitting next to you decides to take a swipe. The reality is that both of those are common in situations of what today we glibly call rural-urban migration. The rapid growth, the chaotic growth, the disorganized growth of cities. And Henry Burgess, a scholar of urbanization, likes to talk about the city as a process of a dialectic process of organization, disorganization, reorganization, and destruction and disorganization. Pregnancy-related problems, of course, just as they are today in many urban areas, were dramatic. And the life of a woman in pregnancy was very short. Let me just say that today, I think we do not understand how privileged we are not to be exposed to that type of pregnancy-related problem. If we were living in Sweden today, the chance of a woman dying in pregnancy would be 1 in 1,700,000 minimum. If she were living in the Congo, it would be 1 in 11. So we must appreciate that with the city, and with science, and with the application of science, has come great progress in the area of health. Not that it was applied at that time, or even today, to those most in need. So, where are we today? Where have we come from since the 1800s? Well, since Saint Xiaoping's statement that being rich or becoming rich is not bad, wonderful statement for a communist, rural-urban migration in China has not ceased to grow. And today, the government estimates are that 3.5 million people move every month from rural areas into cities, primarily on the eastern southern coast. In fact, the government is so enamored with this process that it is made as one of its strategic goals to move another 430 million people in the next 15 years. Now, the Chinese government does this because it says, publicly, that people in urban areas are more intellectually and economically productive. It also says, and this is going back then, in a way, to Machiavelli and to Dick Whittington, but it also says that the value of urbanization is that people who concentrate in cities are easier to reach with health and social services. It's a wonderful statement for the Chinese government to make. In fact, the rural-urban migrants of China today are fitting very clearly into the model that was present in London. Overcrowding, poor dwellings, little access to healthcare, because healthcare, in this wonderful transition that countries make from socialist countries to capitalist countries, healthcare has become privatized and no one can no longer afford it. Their children cannot go to school. So we have a population in China that is becoming a new lumpen proletariat of these massive, millionaire-driven cities. One of the coping mechanisms is for parents to leave their children behind. And it is currently estimated that there are 61 million children in China who have been left behind. Now, we have a picture here of a grandmother. The reality is that if the grandmother is willing and able, that becomes one solution. If the grandmother or the grandparents are not present to do this, you look for alternatives. So we find in China children of 3 left with siblings of 6 and 7. These are their carers. China is not alone in this, by the way. One of the biggest and most frightening phenomena that we are dealing with today in the area of migration are the hundreds of millions of children left behind in the Philippines, in Thailand, in Nicaragua, El Salvador, for Central Asian countries, the stands as we call them. Parents who have to move, but who are not allowed to take their children with them. European countries have evolved a wonderful mechanism for exploitation. Of course you can come and work. We'll give you a contract. We'll give you a contract maybe for 11 months, not 12, because if it's 12 then we have responsibilities for insurance. But you can come for 11 months renewable. But you cannot bring your children with you. And usually you cannot bring your spouse or partner with you. So we have a situation in which parents move often to different countries and leave their children behind. The consequences of this we do not understand yet. But I do know of cases in the Philippines where we have seen mothers coming back from working in the Gulf countries after 15 and 20 years, sending money back for their children, assuming, as people in developing countries always do, that the family is the social security net that we think of as national insurance and pension scheme. And they arrive after all these years, and they knock on the door, and no one knows them. So in the Philippines, we have this growing population of women who have no roots any longer, and no one willing to look after them, and no savings because they send all their money back to the family. The same may be happening in other parts of the world. The Philippines is a country that we look at more closely and know what is happening. So in China, a two-tier system is developing. One in which a large group of people, millions of people, hundreds of millions of people, are unable to access a healthcare system and social services and good housing. Reminiscent of the situation in London, TB, multi-drug resistant TB, is on the increase. Other respiratory diseases, smog-related, and anyone's seen photographs of Beijing and Shanghai under cloud cover realizes just how bad the smog can be. It's reminiscent, I think, of London in the 60s. Malnutrition-related diseases, not necessarily, by the way, undernutrition. There is a problem in China today of overnutrition in migrant workers because they eat cheap food, fast food, This is diabetes-related food. Lots of waterborne diseases. The number of deaths in China from food poisoning would frighten us all from going there to a restaurant. HIV and hepatitis B, major and growing problems. Accidental injuries because of the horrendous working conditions, especially for men, and a growing problem of substance abuse. But rural migration is not limited to China, nor is it limited to the England of the 1800s. It is a growing global phenomenon, unstoppable. No matter where we look, the number of rural people is decreasing and the number of urban people is growing. There is a rush to get to the city. And not surprisingly, the distribution of major cities, what we call megalopolises, is changing rapidly. Unfortunately, many of these cities with 10 million or more people are in countries that have never and never will reach the Millennium Development Goals that were set a few years ago. They're countries that politically are not committed to it, and they're countries in which the infrastructure of health and social services is so far behind that national coverage is almost impossible. So the fact that these 10 million and larger cities are emerging in these countries presents probably one of the biggest challenges, maybe threats, to international as well as national public health that we have ever seen. For those of you who have ever had, quotes, the pleasure of working with the WHO office in Southeast Asia, based in Delhi, this is the view from the back window. An anachronism, if one could ever think of an anachronism. A 100,000 strong slum, literally one canal away from the organization that is supposed to be representing public health and global health. India, of course, is not alone. The situation in the Philippines is pretty much the same. The situation in Mexico is perhaps even worse because in Mexico the poverty is linked with very high rates of violence. And if you go to Nigeria and you cannot swim, then you better be careful. And if you're afraid of heights in Pakistan, don't go. These are the conditions which are emerging in the new urban centers around the world. These are the products of rural-urban migration that is unplanned, that is not organized, that is not registered, and for which countries have no solution at hand. When I worked in Peru, the government did have a solution. And periodically it would come into what we call then the new towns, pueblos nuevos, and they would just simply tear them down. And they were called new towns because the next night they would be rebuilt. They were only made of cardboard and spare wood. But this was the solution that Peru had for the rural-urban migration that it was seeing and which it was dependent upon. Egypt too, and Brazil. So, as the Commission on Health Research says, inequalities are growing. The rich are becoming richer, the poor are becoming poorer, which is not, so dreadful. What is bad is that the rich are becoming healthier and the poor are becoming less well. And this is happening all over the world. Because as we go into one financial crisis after another, expenditures on health are going down. And the populations that are being least well covered are the populations of newcomers in these big, burgeoning cities. A few attempts are made locally. People set up toilets, public toilets. Public, but you pay for them. That's one attempt. And there are, in a sense, things that are happening that remind us so much of John Snow and the cholera epidemics of London. The water that people are consuming in many parts of the world is so poor that unless it is boiled and boiled and boiled and boiled, there is no chance of you drinking it safely. The only way in which we are escaping major cholera epidemics today is the fact that more and more people are turning to very expensive bottled water, which is lowering the water tables of many of the places from which the companies are taking the water to bottle it. But at least it's reasonably clean. Sewage disposal of the kind that happened in the UK in the 1800s is still light years away in many parts of the world. And people live in these conditions, and they swim in this water, and they fish in this water, and they bathe in this water, and they often take the water and then bottle it and drink it. So one of the major differences between the London of the 1800s and the cities that I've been talking about is the fact that London was growing intellectually, technically, and also because there was a political will to do something about the insanity of rural-urban migration. In many of the countries where the large 10 million and 12 million and 15 million person cities are emerging, are cities that are not looking for migrants. London needed migrants. Manchester needed migrants. It needed people to come in and work in the factories. In many of the countries that we're talking about, there are no factories, or not enough factories to justify the type of migration that is taking place. And these are cities that are not growing economically. They're simply surviving on a shoestring operation. These are cities that cannot provide health and education and social services, clean water to the people living in them. And these are countries that are now perfecting. I've put two-tier systems. You could say multiple-tier systems. These are countries in which what Stephen Joseph called in London the underclass, the lumpenproletariat, is not only taken for granted, but is religiously made credible. These are countries in which migrant rights have not been understood, nor have rights of the poor. And these are the cities, I like to say, without the Snows, without the Boos, and the Whiteheads. Because ultimately changes in society, changes in rural-urban settings, come about as a result of individual acts. And unless there is a political and intellectual capacity and commitment, changes will not come about. That's not to say that there are no intelligent people in these cities. On the contrary, there are. But their intelligence is not being directed to dealing with these problems. So, where are we today in developing countries? We are seeing a resurgence of TB, malnutrition, cholera, and violence. I'm not going to talk about Ebola, but that surely must be very much in our minds every time I talk about cholera. They're becoming overwhelmed by new urban diseases. These are diseases, malaria, schistosomiasis, filariasis, leishmaniasis, that one would never have associated with urban environments 50 years ago. These were diseases of rural areas. Today, they are a product of circular migration, and they're entering into the city. Cities like Rio de Janeiro now are major reservoirs of malaria. And this has happened in the last 50 years as a result of this massive migration from malaria endemic rural areas into cities. Same with schistosomiasis. You can go into Brasilia, the capital of Brazil, and find schistosomiasis. How the hell did a snail get from the rural area into this modern, beautiful city of Brasilia? Well, it happens because migrants move in and out with their fishing nets, with their fish, with their fish baskets, which carry the snails, and the snails hop off, if snails can hop off, and settle in these new environments. It is probably one of the most frightening scenarios that we have ever seen. And what is worse, of course, is that many of these cities and the countries in which these cities find themselves are not going to do anything about it because in a financial crisis, this is put on a back burner. But there is also a tremendous lack of international commitment to this. And if I can just dwell on for 1 second on Ebola. Ebola really is a horrendous commentary on the failure of international development. For Ebola to be spreading as it is today, within countries, across borders, on planes, is frightening in 2014. And yet it is happening. So where are we today in Europe? I was going to say here in the UK, we're not in the UK. In the UK, 40% of the entire health workforce is foreign born and has arrived in England in the last 40, 45 years. Throughout Europe, skilled and unskilled workers constitute a population of something like 40 million people today. If we add to this the number of people who come in as non-resident, transitional harvest workers, the number goes up exponentially. And if we think of the refugees that all countries in Europe like to say we don't want any more because we're overwhelmed with refugees, which is of course bullshit, then the number goes up again. And then there are people who manage to move with families, and then all those who move alone because they have to move alone. Those who are young and in principle healthy. Those who we suspect are unhealthy, but maybe very healthy. Those who we don't think about and who are very unhealthy when they arrive. A group of about 400,000 women who are trafficked in Europe every year. And then the migrant sex workers who have changed the pattern of HIV in many European countries, particularly my own country in Spain, from being an injecting drug use related disease to a very heterosexual disease. Each of these groups of people come with very different backgrounds, with very different capacities, with very different needs. Unless we can develop plans, unless we can develop programs, policies, strategies to deal with these differences, but always keeping in mind that these people are essential to the European growth. Let me just take an aside. If we were to look at the pattern of fertility in Europe, we would have to conclude that Europe is a dying continent. For a population to sustain itself, it must have a fertility rate of about 2.1 to 2.2. Most European countries have fertility rates now that are 1 and less than 1. So these are countries that literally cannot survive unless they will bring in or allow in hundreds of thousands more migrants than they are doing today. 10 years ago, the World Bank estimated that if Europe wanted to maintain the quality of life that it had in 1995, it would have to increase its migrant intake by a factor of 17. The response by European governments was make the walls higher, top them with barbed wire. I'm being facetious. But all politicians can talk about is to stop this migration, which is the only thing that will keep European countries behind, alive. And even today, in the UK, the Prime Minister Cameron is having to fight the German government on its position to stop migration. It is a very much ostrich head in the sand type of phenomenon, but one which is becoming very, very pernicious with very long-term and serious implications for demography as well as for health. So today, Europe has, conservatively, something like 60 to 70 million people who fall under the classification of migrant. Now, this is a lot. It is almost as many as the number of Europeans who left to go to the so-called New World between 1860 and 1930. Our great-grandfathers, or in some cases grandfathers, who left for the United States, for Canada, for Australia, New Zealand, and so on. There are very few European countries that have developed policies of social integration. In many countries, there has been a laissez-faire approach. The belief that all groups can maintain their own cultural identity, which is wonderful. But what it means is that we have a lot of very distinct populations in Europe now. And if we were to look, for example, at maternal and child health indicators, pregnancy outcome indicators for Moroccans in this country, we would be shocked to find not only are they bad, but they've not changed in the last 25 years. So we're beginning to get an intergenerational problem in which poor health behavior, inappropriate use of health systems and services moves from one generation to another. Frightening. We have not developed any real screening systems. People come in and out, and we don't know what they bring with them. And of course, screening can be very dangerous. Screening without treatment is unethical. So screening must always be done with the aim of providing treatment. Many European countries use screening in order to reject people. So screening has a bad term, has a bad aura about it. And many people will avoid it. So even if today we were to introduce screening, for example, for hepatitis B and C, which we should, many people, many foreign people, foreign-born people, would avoid screening because they associate screening with some type of repressive response. There is throughout Europe a tendency, and I've taken a term that was coined by Daniel Moynihan in the United States many years ago when he was talking about race relations in the United States. there is a policy of benign neglect. You neglect them not aggressively, but you do it passively, but you neglect them. And that is what is happening to many of our migrant populations in Europe. So today, if we were to look at hepatitis B and C, we would regrettably have to conclude that this is 80% migrant-related. The pattern of hepatitis B and C in Europe is changing. It's changing very, very quickly, very dramatically, as a result of migration. But more particularly, because we cannot take the time to screen and provide treatment. We're finding that HIV is mimicking HIV patterns in the countries of origin. Well, that's a terrible indictment. What it means is that people moving into London who come from a country with a high prevalence of HIV may be moving into an ethnic community where the same customs, where the same lack of information, the same ignorance of the problem, the same unwillingness to do anything about it is continuing to persist. Multi-drug resistant TB, for which there are very few treatments available, is on the increase. And this too is migrant related because our screening for TB is very inefficient and our screening for latent TB is non-existent. But it's all available. It could be done. And a few years ago we did a study of substance abuse in migrant populations in 6 cities in Europe and found that drug dealers are very, very good sociologists. They understand vulnerability. They understand the fragility of children of migrants. And they know how to target them. And they do target them. And this is a major problem, and one that, again, we're not acknowledging sufficiently well. The poor maternal indicators I've already spoken about. So what has worked so far in developing countries? The emergence of new cities, smaller cities, cities like Abuja in Nigeria. How long it will remain small is another question. A renewed interest and commitment to family planning, but more importantly, an intensified rural development strategy by many of the major UN agencies, and international assistance for what we might call evidence-based planning. And this has come about, frankly, as a result of HIV. The assistance that international HIV programs have given to countries so that they can plan their situations, can plan their strategies, can estimate their resources, and make bids for new resources has brought about a whirlwind of change. Unfortunately, a lot of these actions have been counterbalanced, counteracted by conflicts, and no region of the world has seen so much political instability in the last 60 years, because after all, we Europeans perfected conflict and instability. But no region has seen so much conflict and instability in the last 60 years as Africa and parts of Latin America. And this has served to set back progress with regard to urban development, urban planning, rural development and investments in rural areas. The current financial crises are making the situation only worse. And I think we have to be very frank and say that the lack of political will, and I didn't put it down here, but we could add it verbally, the high rate of corruption in many of the countries is working against any real progress in health today. And there's also a lack of international commitment, and again I repeat that Ebola today is a reflection of a very failed international development strategy. So what has worked so far in Europe? Nature. I think we're very lucky that most migrants are young or young enough that they're not suffering from many of the diseases that we have, certainly my age. They will develop, but when they come, they're relatively healthy. And this has saved Europe. Cultural competency programs are on the increase, and I've put in parentheses pharma. The pharmaceutical industry is the one that is most committed to competency training, cultural competency training, for very pragmatic reasons. If you're health illiterate, if you do not understand your prescription, if you cannot speak clearly with your physician, the chances are that you will not follow the treatment regimen correctly. And it is the treatment and the drug that will be criticized. So pharmaceutical industries are interested in this and are investing in it. Regrettably, governments are not. The other saving feature is, of course, migrants today are smarter than we used to be. They understand their predicament. They can work for their own health. They are more literate. Many of them arrive to clean restaurants with PhDs and, in many cases, drive taxis with MDs. They are willing and able to play a role in their own health, and there are many community projects developed within migrant communities that are now far more successful than national or local health authority programs. And ironically, the lack of resources available to national and local and regional authorities is making these authorities say, well, go ahead, why don't you do it? And we'll give you a small amount of support so that you can do it. And they will do it. And they may do it better than we have been able to do in the past. And there is a new social epidemiology emerging. And I think this has emerged in the framework of HIV. Taking the principles of epidemiology and interjecting some of the social science knowledge and coming up with a new mix that looks not only at the prevalence, the incidence and prevalence and the distribution of diseases, but also the behaviors that go around them and the responses that go to those diseases. And more than anything, a new rights approach, which is clearly coming out of the HIV arena. I think in WHO, before the global program on AIDS, I certainly never heard anyone talk about rights, human rights, or anybody's rights. HIV forced people to come to terms with the rights of patients, with the rights of people living with HIV. And from that it expanded and has become a major, major governing philosophy in health in general. And the crisis for resources is also forcing us to become far more evidence-based in medicine and public health. Today it is very difficult to take a decision, a prescriptive decision, without thinking about what do we know about, from the evidence, from the epidemiological evidence, about the diagnosis, the treatment, and the anticipated outcomes. And this is a major, major breakthrough. So, to end, before we all fall asleep, if not for ethical reasons, and I wish it were for ethical reasons, but I am not so idealistic or naive to think that we can expect too much in that arena. In an era of not cholera, but in an era of Ebola, when we know how quickly viral and bacterial agents can be moved, faster than their incubation period, silently, invisibly, from one part of the world to another, surely this is a time when we need to think about what is it that this migration framework in which we live requires? What types of strategic approaches does it need? What types of policies are required? What types of new practices are required keeping in mind that it is not only the health of the migrant, it is not only the health of people that they sit on the bus next to, but it's also the health of the people that they leave behind. We really are on the verge of probably one of the most fragile periods, demographically, socially, politically, and certainly in terms of health, that we've ever seen, as a result of this vast, rapid movement of people, not only rural, urban, but cross-border migration. So that is my plea. Let's try to do something. Let's try to focus more on this issue. Let's try to convert some of our other interests and activities onto this emerging challenge. Thank you.